Hello everybody, I am Dr. D. Prabhu. So today our main discussion is about an analysis of Indian critical care delivery in government sectors and its impact on general public. To say on this presentation, actually Indian critical care means mostly in the government sector, government hospitals, critical care, that is ICU, intensive care unit or critical care with ventilators, were very pathetic in state. So what happened is, like, general public have underwent a strong they have faced lots of misery and problems. So this problem, this presentation is about to highlight how is the status of critical care and how we are going to set right it. So introduction. Poverty is directly linked to public health care delivery in many ways and dimensions. Every aspect of human sphere is pre-planned, but health crisis is the only emergency which pushes humanity into severe economic stress. So the aim of every nation is to safeguard its citizens from health crisis. That is a priority area for every country in this globe. In this aspect, India needs to improve its public health infrastructure to safeguard its citizens and save from poverty. You can ask me how come healthcare is directly related to poverty. When a person is critically ill, either it be due to pandemic like COVID or in case of emergency situations where he's been pushed into critical care, most of the people, most of the cost of critical care is almost very exorbitant, which at least takes 7 months of Indians' average salary per day admission in an hospital. So to assess the aims and objectives of this presentation is to assess the current pitfalls in public critical healthcare delivery, to analyze whether the healthcare delivery matches the requirements of its population in every state of India, and to provide solution and guidelines to overcome the stress in this priority area. So methodology, how did we analyze, how we came to conclusion about the current status of public health care in government hospitals across India and even in private hospitals across in India. The methodology is data regarding the critical care manpower, something like doctors, nurses, which includes critical care doctors, nurses, were taken from official website of medical councils, nursing councils and concerned health intelligence websites of central government. So critical care infrastructure data was retrieved from internet sources. There are multiple sources available and multiple papers available on the current position of critical care medicine, critical care infrastructure in each and every hospital of India. So data was validated by consulting state government sources and checked for bias elimination. SPSS software were used to analyze this data, and data was presented using descriptive statistics, SPSS software. Why I'm explaining is, we are not just complaining or we are not just finding fault in the system. Our aim is to scientifically analyze this crucial part of healthcare and suggest suggestions to the government to act as early as possible to save common public from misery. So the result was really, first we analyzed the prevalence, how much infrastructure is there and what is the condition, and it was really pathetic and very, very, very shocking. The result is, there is if a requirement is for 10 members, either let it be beds or whatever it is, 10 members, the real thing what is available is just one. That means if 10 doctors are needed, only one doctor is there in the field. If 10 beds are required, only one bed is there. So the requirement only is already less. Requirement is for 100 population, 1% is the thing which we are requiring. 1 to 5% is the minimal requirement what we are speaking about. In that minimal requirement also, for 10 requirements, only one is there. So such pathetic is our condition right now. Critical care medicine are in 1:75 when compared to other specialties. If an orthopedician 75 members are there, only one critical care member is there. This is the result. And to highlight it with proper tables, total number of ICU beds for total population is charted out in this table. For an example, for the total census, total ICU, in ICU beds in Uttar Pradesh in public sector, that is in government sector, is just 3,813. Whereas in private sector, it is 10,257. In Tamil Nadu, 3,877 is in public sector, and in private sector, it is in 3,892. So in Tamil Nadu, at least 50% of ICU beds are in private as well as public. But when you take Uttar Pradesh kind of largest state, for each and four every beds, ICU beds available, only one is from government sector, remaining three are private. Then you know how much private charges and private runs on profit motto. Then you can understand the plight of public, how much would be the expense of the public in such a critical care situation, how much they could have undergone misery mentally and economically in such states. So this paper is to highlight that the earliest correction is needed in this section. So when we come into the estimated ICU total beds available, when you see for total beds available from Uttarakhand, it is somewhere around 1,192 to Lakshadweep, it is 21. So there is a lot of disparity, but whatever may be the population, for 100 population, the requirement is 1 to 5%. So 5% could have been a better idea, at least 1%. It should be there. Either it be manpower or else let it be infrastructure or whatever it may be. That too, we need it in public sector. That is the high point. So totally, when we see the percentage of beds, ICU, infrastructure, which is in Uttar Pradesh, in 100% of the ICU beds which is available, only 27% is in government sector. Remaining 72% is in private sector. So, you know, you can understand private runs on clearly business motto. Their aim is to make money. So 72% of the beds, if it is in private sector, then you think how much public will be held, how much public can be served with free service from government. So what happens? Automatically a person in a household, a marriage or education is a foreseen expense. But when it comes to public health care, when it comes to critical care, it is unforeseen always, and it drains the pocket like anything. So when you come to Tamil Nadu, the position is at least okay, 50% of the bed is in public and private. But still, this is based on the beds which is already available only, how much is in private and public. This table doesn't mention about the requirement. When you go to requirement, it is already very pathetically low. So total percentage of ICU beds in public and private sector, it has been given in this chart, which is continuation of the previous slide. So now coming to the proportion of ICU beds and ventilators to total population. When you see, we require 1% minimum or to 5% minimum per 100 population, but in Uttar Pradesh it is pathetically 0.007. How far from 1% minimum requirement you see? That is the reason during this pandemic, lot of public underwent misery. All the ambulances were strangulated outside the arterial roads of hospitals without beds. For a country which is going to be at par with the top 5 economies in the world, India is marching towards that. Is this the healthcare which we want? Is this the priority? Is this the infrastructure? Is it enough for catering to that level of top 5 economic countries? I mean, that means what? People are earning and making the country rich. They are contributing heavily to economy, but country is not repaying the public in the top priority of healthcare. That too, in a dire life-saving situation like this critical care. So lot of people all around India ran around from pillar to post with misery, not only of healthcare, disease burden, but also on economic front. And lot of people were being pushed to poverty because of this. So this paper aims to highlight the misery of common man. So when it comes to developed states like even Tamil Nadu, it is just 0.01%. 0.01%, and the requirement is 1% to 5%. 5% if we keep, it is one of the best targets. So coming to ventilators, the same thing continues, the same pro forma. Okay, leave the infrastructure. It is not be that in a nutshell, that means that not even 1% we have infrastructure. When it comes to specialties and manpower, When you compare, there are in India per year 1,230 people, ophthalmologists pass out, but only 84 emergency medicine seats. So it is government's priority to increase the seats also. So when it comes to ventilators, it is also showing very pathetic results. It is showing very pathetic result. Come back. So coming to discussion part. So at least 1 to 5% of critical care with ventilators are must to care from general public to care for prompt general public. But in most state of India, it is quite lesser than 1%. And the value it is in decimals, which shows the lack of appropriate planning and prioritization in public health care. The economic burden is such that even per day, one ICU, one bed charge is equal to 7 months average salary of an Indian. That means if one Indian wants to go and get admitted in a private hospital for an ICU, per day charges are equal to 7 months average salary of an Indian. So per day only, or for 1 day only, is spending around 7 months salary. So if the person is lying down in a bed for 10 days, what should be the condition? Do the families don't go bankrupt? Doesn't the government responsibility to keep this as a priority and rectify this condition? Yes. This alarming condition needs priority action with out-of-box solution, or else it would be a disaster by only projecting our nation's economic growth. But in reality, the general public is pushed into misery. So strengths and limitations. India being economic and knowledge superpower, it has the potentials to raise the standards of critical care and bring people out of misery. That is a strength. But limitation is a lack in strong political will and a lack in prioritizing skill sets in healthcare governance will always create limitation in this largest democracy. That means what? The strength is we are a superpower in IT. We are top 5 in the top 5 economic power. So we have technology also, money also. But our governance and lack of skill set to prioritize critical care, and instead of building bridges, IT parks, is it not the government's responsibility to fix this critical care in public sectors? That means in all government hospitals, it needs a revamp in critical care. For every 100 beds which is available, at least 1 to 5 beds should be critical care beds, which is equipped with all kind of medicines, infrastructure, and manpower. So government should form a priority task force to solve this problem, or else this misery after 75th year of independence in India, it is going to continue for hundreds of years if it goes unnoticed. So the priority of this paper is to bring and highlight the misery of common man during critical care positions. Not only this pandemic, leave pandemic. Today pandemic will go, but some other thing will come. And even a person with a kind of accident will land in critical care. So we need to give a top class care, leave headache or when an orthopedic situation that can be cured with time and with kind of less money. But critical care is life-threatening condition where government should act in priority, and that too public sector infrastructure should be spruced up. Being second most populated country or first densely populated country in the world, what we need is for this population, the kind of public health care, the kind of ICU beds, the kind of critical care infrastructure plus manpower is very, very, very pathetic, which India should awake at the earliest and go for it. So the aim of this presentation is to reach the people who are in health planning and governance so that this condition can be highlighted and take the public out of misery. Since India is considered as fast-growing economy, but still there is huge disparity in public health critical care. So with out-of-box idea, we expect the governance and policy planners to put the mind for this and bring people out of this kind of misery, either in economic or else as well as disease burden. And in next presentation, we are going to much more and we are going to analyze this problem in depth and bring out with out-of-box solution so that it can be a recommendation for all the health planners and let this presentation pave way for moving forward in right direction for a strengthened nation. Thank you.